Good afternoon, and thank you all for joining the Merrick Company Science and Technology webinar series. My name is Kelsey Judd, and I'm the Operations Manager for Science and Technology Programs at Merrick, and I'll be doing a quick introduction of the webinar and our presenters. Today's webinar is using the elements of public health risk assessment to define returning to work strategies under COVID-19. The webinar will be presented by Dr. Ryan Burnett, Director of Science and Technology Programs, and Samantha Dietrich, Global Health Security Lead. Before we begin, I'd like to share just a few details about the mechanics of the webinar. All participants are going to be muted, but if you have a question at any time, please use the question box on the GoToWebinar control panel, and we'll do our best to address them as they come in. Additionally, if you have any questions or technical difficulties about the presentation, please also use the questions box feature. Finally, today's webinar will feature a poll at the end of the presentation. We appreciate you taking the time to complete it. Now to introduce today's presenters. Dr. Ryan Burnett is the Director of Science and Technology Programs in the Life Sciences practice at Merrick Company. He is an international biorisk management practitioner, having worked on projects in the US in over 50 countries. He has consulted on biocontainment, biosafety, and biosecurity programs and has built relationships with clients and stakeholders in academia, biotech, pharmaceutical, and government. Dr. Burnett is also the author and editor of one of the authoritative volumes in biosecurity entitled Biosecurity: Understanding, Assessing, and Preventing the Threat. Next, we have Ms. Samantha Dietrich. Sam is the Global Health Security Lead for Merrick Science and Technology Programs. She has nearly 15 years of domestic and international experience in global health security, public health, and pharmacovigilance in infectious and non-infectious diseases. With an extensive background in epidemiology, laboratory and health system strengthening, and program management, Ms. Dietrich has worked with both government and non-government entities in Africa, the Caribbean, Central Asia, Europe, the Middle East, North America, and Southeast Asia. So moving on, here's the agenda for today's webinar. This is a public-facing presentation, so we'd like to begin with a brief introduction of who we are at Merrick and why we care about this topic. Then we'll move into the current status of the pandemic, what to expect over the course of the pandemic, what is a public health risk assessment, how to apply concept of a public health risk assessment to your return to work approach, where to get trustworthy information, and why it's critical to take personal accountability. So for a brief introduction of who we are and why we care, Merrick has been around for over 60 years and is historically a multidiscipline architecture and engineering firm. And over the past 20 years, the company has moved into life sciences work through lab design, facility operational planning, and biorisk management consulting. Our 6 business units serve 4 primary markets: energy, national security, life sciences, and infrastructure. Focusing a bit on life sciences, we have broad expertise and work in many different markets, including federal, academia, private and commercial, healthcare, science and technology, and global health security. Merrick has about 700 employees spread across 22 office locations in the US, Canada, Mexico, and the UK. And we've worked globally in more than 50 countries on every continent, with a vast majority of these international projects being for life sciences clients. At Merrick, we strongly believe the why is more important than the what. The life sciences team is made up of design and commissioning staff with a wide array of technical professionals, including scientists, veterinarians, public health professionals, biosafety and biosecurity experts, and several others you can see here. It's the passion these individuals have for their line of work that make webinars like this possible. At Merrick, we're dedicated to continuous improvement in the life sciences, whether it's in the laboratory, food and agriculture, biopharmaceuticals, research, or public health. And with that introduction, and now that you know a little bit more about who we are and what we do, I'd like to pass it on over to Sam to provide an analysis of where we are in the pandemic.
Great, thank you, Kelsey. Good afternoon, everyone. As we're starting off this presentation, where we are in this pandemic. It's been a couple months now since this pandemic has really hit the US. So we'll start off with some background slides and go on from there. So let's first begin with a little bit of background information. As with any disease, it's important to understand what it is, what the symptoms are, and how it spreads. So first, a point of clarification of the terminology. COVID-19 is the disease or the viral infection. The virus itself, though, is called SARS-CoV-2 and is sometimes referred to as the 2019 novel coronavirus. It belongs to a family of viruses known as coronaviruses. These viruses are named for their crown-like spikes on their surfaces. They infect mostly bats, pigs, and small animals, but they can mutate easily and jump from animals to humans, as well as from one human to another. COVID-19 is a respiratory disease. Initial symptoms include fever, cough, and aches, and can progress to shortness of breath. Other symptoms can include chills, sore throat, muscle pain, headache, and loss of taste or smell. The incubation period is 2 to 14 days. This means that after you're exposed, you'll start to show symptoms anywhere between 2 and 14 days. The virus that causes COVID-19 is thought to be spread mainly from person to person through respiratory droplets produced when an infected person coughs, sneezes, and even talks. These droplets can land in the mouth or nose of people who are nearby or possibly be inhaled into the lungs. Spread is more likely when people are in close contact with one another within about 6 feet or so. It may be possible that a person can get COVID-19 by touching a surface or object like a table or a countertop that has the virus on it, and then immediately touching their own mouth, nose, or possibly their eyes. But this is not thought to be the main way that the virus spreads. COVID-19 seems to be spreading easily and sustainably in the community, also known as community spread, in many affected geographic areas. Community spread means people have been infected with the virus in an area, including some who are not sure how or where they became infected. In terms of who's impacted, when we look at who this disease is affecting and who can get the disease, everyone is at risk. We've seen that children and young adults are less affected, and that there's a higher risk of serious illness in the elderly, along with those with chronic medical conditions such as cardiovascular disease, diabetes, chronic respiratory disease, hypertension, and cancer. I mentioned this on the first slide, but people can start experiencing symptoms anytime between 2 and 14 days of exposure. Many people with COVID-19 may only experience mild symptoms and may not even need to go to the doctor or the hospital. What's important to note is that many people may be asymptomatic and show no signs or symptoms of the virus. What we've learned recently is that people are actually more contagious at the onset of the virus and when they might not know that they're sick. Given that the disease can affect everyone, by not getting infected, you can protect those around you. I think a question that everyone has asked at some point is, when will this be over? And unfortunately, the short answer is that nobody knows. When we think about pandemics and epidemics, what I would say your garden variety pandemic has essentially 4 acts. The first grows very slowly, resembling a slow linear curve, even though exponential growth is marshaling its forces. After that, cases can spike dramatically, infecting more and more individuals every day and registering wide public attention. There are 2 scenes in the second act. In the beginning, most people test positive every day than the day before. This is a hallmark of what we call exponential growth, where we see an acceleration of the cases as indicated by this chart, when the number of cases is not only growing but accelerating. At some point in this case, early around April here in the United States, acceleration starts to slow at what's known as an inflection point. The number of daily cases continue to grow compared to the previous day, but not as rapidly as before. The sooner policy interventions like school closings and stay-at-home work orders are put in place, the sooner one reaches the critical midpoint. Then we see in Act 3, the curve flattens with approximately the same number of new infections reported every day. This is a phase that early on all of us were hoping for, the celebrated flattening the curve. But this does not mean that it's the end of the play. The flattened curve only suggests that some measures of control over the situation, but is by no means the end. There's still a large number of new infections every day, even if that number is constant. Ideally, a flattened curve leads to a squashed one in Act 4. This is the moment when there are fewer new positive cases daily than that there were yesterday. The longer the fourth act can be drawn out, the closer we come to the final stage act at the end of the play. Nationally, the US has returned to a flattened curve where cases are neither spiking nor declining, which is why we're starting to see stay-at-home work orders being lifted in some states and reopening of businesses. For COVID-19, I don't think this is what we would call a typical pandemic. With the re-entry, we're likely going to see an Act 5, where in some states we've already began to see cases climb again. Since the first corona case was confirmed in the US back in January, over 1 million people have been confirmed with cases of COVID-19. In mid-April, the US became the nation with the most deaths globally, but there are early signs that the US case and death counts may be leveling off as the growth of new cases and death plateaus. What's important to understand is that pattern isn't consistent across the country as new hotspots emerge and others subside. What to expect over the course of the pandemic? As I mentioned, we're not at the end. We're not even close to the end, unfortunately, but some states and localities are beginning to reopen, and we're going to see others remain closed and stay-at-home work orders in place. Regardless as to whether a community reopens or remains closed, the key to preventing people from getting sick is to isolate anyone who is sick and quarantine anyone who may have been in contact with that person who's sick. Testing is and will continue to remain a critical way to identify those that are ill, but if someone is not feeling well, it is his or her responsibility to stay at home and isolate themselves from others. We'll talk more about personal accountability a little later on. In terms of reopening, this is going to be a gradual and in some cases a phased approach. I don't think things are going to ever return back to normal, but things will become the new normal. For example, in replace of handshaking, we might see more people say namaste or bow to start off a business meeting. Cloth face masks are going to be the new fashion accessory, and everyone is going to be more mindful of the things that they touch, whether it's an elevator button or the handles on the escalator. Truly, for the pandemic to be over, we're going to need treatment options to reduce the number of people who seriously become ill and even die. And ultimately, we need a vaccine that's actually going to stop the transition. Although there are some promised vaccines in the work, we likely won't see a new vaccine until at least the beginning of the new year. Until then, we need to make sure that people continue to abide by some of the social distancing guidelines that have already been in place and continue to refrain from, if they are feeling ill, or refrain from contact with other people. Now going to turn over to Dr. Brian Burnett.
Thanks, Sam. Thanks everybody again for signing into this. As the name of the webinar implied, we're really looking at a risk assessment approach. Despite the risk landscape still being that we don't have a vaccine yet, as Sam mentioned, we are starting to see states and municipalities reopening somewhat in a phased approach and a cautious approach. So we thought that we would spend a little bit of time and talk about exactly why we felt that that paradigm of a public health risk assessment, which we'll explain what that is, how that could be applied to what we might be thinking about in terms of returning to work in a safe manner. So let me talk a little bit about the risk landscape here. I think a couple of things that are important. I realize not everybody is a risk management professional, and nor do they need to be, but I think that the vocabulary is important here. When we think about a risk is, it's really describing a probability. Oftentimes we tend to describe a risk as a thing, and that's not the case. Risk talks about probabilities. One of the ways that we can think about what a risk landscape looks like is the directionality and the impact and the likelihood that a consequence will occur. So what you're looking at here, this table I snagged from the World Economic Forum. This was actually survey data that was collected over 2014 and 2015. And some of the elements of this that I appreciate when sort of describing a risk landscape is the impact and the likelihood. And you can see that on the respective axes. The other thing that this shows is sort of those trend lines. And the nature of this survey was based around risk perception. So those that were surveyed were asked about these various elements and their perspectives of did they think that risk was, which direction was it moving? And that's sort of indicated by the tails that you see here. What I'll call your attention to, what, a little bit ironic at this date and time, but if you look in the survey responses that were collected and disseminated in 2016, sort of in the upper left, you can see the spread of infectious diseases. Looked like the perception was, maybe we were getting better at that. Then 2020 hit. So, but what this does is this sort of gives you a sense of the risk landscape. And I think that directionality is important, and we're going to talk about that as we go through this. So here's the same hypothetical pandemic a graph that Sam showed a few slides earlier. And on the left, I've got a few bullet points that describe a little bit about the timeline of what we've experienced to date, going all the way back to 31 December in China, all the way up to today here in the US. And it's really disturbing that I updated that 48 hours ago, and those numbers are quite different already, as they are every single day in terms of number of cases and number of deaths in the US. So Sam did an excellent job of describing this from the various acts of the pandemic. And what I want to draw folks' attention to, because this is going to become important for doing your own risk assessment as you go back to work, is the risk landscape that perhaps observation of curves like this can tell us about our relative risk as we try to step outside of our homes, perhaps for the first time in earnest in some time. So let's take a minute and think about what that looks like. If we are on the far left of this curve, actually, let me go to the timeline. Let's say that here we are in the United States. The risk to any one person in the United States, this is overly generalized, on December 31st of contracting coronavirus, probably pretty low. Today, we have over 1 million confirmed cases. That's not an accurate representation of what the true incidence rate, incidence levels are. The risk is higher. So there was less chance walking through your Walmart in December of catching coronavirus than there would be today. That's what I mean by a dynamic risk landscape. So here's sort of the bottom line of where we are. I think Sam has done an excellent job of setting this up. The bottom line is there is no vaccine and there is no herd immunity. So I think the tough pill for a lot of us to swallow, we understand the economic impacts of what we're going through right now. We want to mitigate that as well we can. But we're still, I think, even the most optimistic ranges of having a vaccine available are somewhere in the 12 to 18 month range. And for those of us that understand vaccine production and distribution, that's crazy fast. So what has changed in the risk landscape since we all retreated to our homes to hide from this for the past 6, 8, 10 weeks, wherever you are in that, versus, say, this coming Monday, when maybe certain offices and workplaces are thinking about resuming work? Essentially, one could say nothing has changed. The disease is still out there and we still don't have a vaccine. We're just as susceptible as we were when we decided to hide. Another point might be, actually, that number has gone up. The risk has gone up. Why is that? Well, let me go back to my bowl of M&Ms. Let's say you're just a regular M&M. And there's one Skittle in the bowl. What's the likelihood or the probability or the risk of encountering that one Skittle? Pretty low. But if the number of Skittles go up, then your probability goes up of encountering that Skittle in the bowl. To add to that, I think putting Skittles in a bowl of M&Ms is also diabolical, which I figured would get everyone's attention. So that's a little bit about the risk landscape. Let's shift gears to the public health risk assessment. And for those that are familiar with the public health risk assessment, they might be scratching their heads and thinking, well, usually PHRAs are conducted for use of chemicals, environmental contaminants or pollutants. What is it about that particular approach that seems to bode well when we think about what it's going to take to go back to our workplace? We're going to share a little bit about the methodology and behind doing a public health risk assessment and the elements that we felt were somewhat relevant and perhaps useful and easy to apply. So you can see there's some definitions here on the left. One comes from EPA, the other from CDC. And as it says, public health risk assessments are, in fact, often used for assessing the impacts to public health with respect to chemicals, hazardous waste, heavy metals, environmental contaminants, not necessarily infectious diseases. If you look at some of the EPA methodology in terms of sampling and statistics, the EPA approach for a PHRA can be quite quantitative. So why would we even pretend to apply this in the situation with COVID-19? For a couple of reasons, and I think the subsequent slides will demonstrate this further. One, the focus is on human health, and of course that's exactly what we're focused on. The risk assessment process is also adaptable. We're going to show you the parts and pieces that we think can be applied. And of course, the outputs that come from this in terms of communicating about what those health risks and potential effects are that might dictate the behaviors that we choose to engage or not can be pretty clear. So then you might ask, okay, well then how is this different from a normal risk assessment? Well, in a lot of ways it's not. And we're going to talk about some of those methodologies. What we do like about this is that it focuses more closely on site-specific exposure conditions. So the conditions that are presented to a workplace in California may be very different than those presented to a workplace in Kansas. So broad stroke peanut butter spread guidance may not be everything you need it to be to inform the proper approach to get back to work. There's also specific community health concerns and health outcome data that come from these. So it really is driven at community and individual health. And finally, for those of us that are not quantitative or mathematical whizzes, this is a less theoretical approach. We're really going to look into the qualifying approach to these things, not necessarily the quantitative approaches. But applying this to COVID-19 does mean we're going to diverge from the concept of sampling data, like you might think about doing in groundwater. So let's talk a little bit about the process. I mentioned that one of the reasons we like the PHRA approach is because it's very site-specific. We're looking for site information, and I'm going to give you some examples of what I mean by site information as we go forward. There are really two big buckets of evaluation in a PHRA. There's the evaluation of exposure. So we're looking at the environment conditions. That can be the workplace, that can be the surrounding area where employees live, exposure pathways. So we talk about routes of exposure a lot in other forms of risk management, such as biosafety, where we really think about inhalation, ingestion, contact with mucous membranes, those types of exposure pathways. In this setting, of course, we're really looking for trying to think about how can one become exposed because of conditions that are presented in the environment. So there's a lot of evaluation that occurs in this perspective. And then there's the evaluation of the health effects, which is also informed by site information. And in the evaluation of the health effects, we're really looking at identifying the pathways and the agents that can cause negative health effects, and then determining the public health implications. Now, for our purposes, in many respects, we have a lot of data on this already with respect to COVID-19. We are still gathering data, but I think we all still agree on what the end game is, and that is the probability of contracting a disease for which there is currently no vaccine. So, got a pretty good handle on the evaluation of health effects, and it continues to grow. What we do with these data is we can determine public health conclusions, and we can determine the actions that we want to take. The final piece of this simplified public health risk assessment process that I think is critical is the risk communication. So we're going to talk a lot about risk communication in this because we're not communicating to a laboratory now, right, where everybody has a master's or a PhD in the biological sciences. This risk communication is important no matter what the audience is, no matter where folks come from, what their educational background is, it just doesn't matter. So the information has to be relayed appropriately. So it's sort of like saying, you know, what you say is as important as how you say it. So I want to dig a little bit deeper into the evaluation of exposure, which is in that first bucket of the public health risk assessment process. Let's look at the environmental conditions. So on the right, you can see a sort of a schematic architectural layout, perhaps a prototypical, albeit looks pretty snazzy, office space. And in that office space, we can see that there's a break room and kitchenette up on the top left. You've got some open meeting space on the bottom right, conference room towards the bottom, looks like an executive office in the top right. You have a lot of different areas here. So we really need to understand what challenges does the workplace present to us, whether this is an office, whether this is a manufacturing facility, or a call center. And can you effectively employ reduced numbers of personnel and physical distancing? So we really have to think about if we're going to adhere to the physical distancing guidelines that we know we should be, how do we do that? And can we make that happen safely in our environment? Do you need additional measures? We're going to talk about this as well. Maybe we're going to have to move some furniture around. We're going to have to get creative. And then, of course, taking a look at, you know, where do folks typically congregate or gather, and how do we mitigate those things? When we talk about the exposure pathways, which is the other half of that first big bucket in the PHRA process, we're really looking at trying to ask ourselves candidly and honestly, have we identified the exposure points? Is that a water fountain? Is that a copier? Those elevator buttons? Have you identified the exposure routes, whether it's inhalation, dermal, contact, what have you? And have you identified a potentially exposed population? So I think one of the points that we really want to make, that Sam made at the beginning of this and that I will reiterate, is the primary risk of contracting the disease is presented by another person that has the disease. It is minimizing the exposure to that. That is the basis for all of the physical distancing that we have gotten. It is certainly possible to contract the disease and become infected through making contact with contaminated surfaces. But the vast majority, when we think about what is the real source of risk here, the real source of contracting the disease, it's going to be through somebody that already has it. It's important to make the point about what risk tolerance is. In a large way, the federal government and our state governments, and perhaps even our local governments, have made I don't know how informed they are across the board, but somewhat of an informed decision of a risk tolerance. And this means we're willing to take these risks, open these doors, allow things to resume back to, you know, at least in the positive direction of economic stability and recovery. And we know that because of that choice, people are going to die. I think that most of us don't like to admit that, but I think we all know that that is sort of the binary choice. And I realize it's not binary and there's a lot of gray in there. But we know what the primary sources of risk are. And we know that when we go out and mingle with a population of unknown status, our risks increase. Let's bring this back down to the workplace, however. What is the tolerance of an individual workplace and the stakeholders that have the ability to determine what those tolerances should be? That's an independent choice. That's not a choice that somebody can make for you. You might totally agree with the broad guidance that has come out from either the federal government, state government, or local government, and you intend to follow that. The whole purpose of this webinar is to advocate for a more site-specific, risk-based approach that goes beyond what general peanut butter spread guidance may be. So what you're looking at here on the right, obviously, this is a chart that sort of describes the different tolerance levels, and this is just an example. And we really look at two elements: the frequency that an event can occur, and the severity, and the amount of impact that that event will have. And category A being intolerable. This must be fixed. B is, you know what, this is still pretty significant. Don't know if we can tolerate that or not. We're going to need more information. C means, okay, that's tolerable. These are risks we can mitigate. D essentially means negligible risk. Interesting, the Philadelphia Medical Society had this little snapshot that I snagged that I thought was very useful. It's very simplistic, but it shows how they've ascribed things to either high, medium, or low risk. They've given definitions for their healthcare providers, and they've provided some of the public health actions. So going back to that PHRA process, it really follows that model, which I think is very nice. I talked about risk communication. I think this is going to be very critical. I've always loved this graphic from FAO, and it really shows the science-based risk assessment overlapping with the policy-based, so sort of the folks making decisions, deciding how things are going to operate, and that overlap. When you encapsulate all of those, you really have to use both of those to communicate what the risks are to the employees, the community, whoever it is that you might represent. So it really does refer to the exchange of real-time information, informed opinions. Hopefully you've got some good in-the-know experts that are helping this. And as WHO defines here, we're really focused on tackling threats to health, economic, or social well-being. I mentioned this before, but what you say and how you say it are equally important. That being said, Sam and I are going to tag team a little bit of a case study. Sam, why don't you start us off?
Great, thank you, Ryan. So in applying this process, what we did was look at Merrick's Greenwood Village office in Colorado. So in terms of the public health risk assessment, the goals are really to look at how science and health-based data can inform the reopening or reentry strategy for the office in Greenwood Village, and how sustained safe operations can be maintained until there is the vaccine available and or herd immunity. Part of this reason was to ensure that Merrick employees had the confidence in knowing that leadership was able to provide a well-informed approach with employees' interest in mind, and that their own behavior and control of their environment as they venture out. So as Ryan discussed before, the main criteria for the public health risk assessment was the environmental considerations, as well as looking at the exposure pathways for the specific site, which in this case, again, is the Greenwood Village office. In terms of the process, this is a step approach where, as Ryan mentioned, it's very site specific. So in terms of looking at Greenwood Village, we initially developed a questionnaire, so a series of questions that we wanted to make sure that we asked to obtain those site-specific details. The questionnaire really looked at, again, some of those environmental conditions as well as potential exposure pathways. We then conducted an interview with the site stakeholder, primarily the office manager at the Greenwood Village office, looked at any landlord-issued guidance, so understanding that the buildings that we rent, in this case in Greenwood Village, there may be specific guidance that's been issued by the actual building manager or landlord. So we felt that that was important to attain. We then conduct the risk assessment and generate a report and creating training slides. So looking at the information that we received, the site-specific information, as well as what some of those environmental conditions are, exposure pathways, and then being able to generate that report, which outlines some of our recommendations, as well as creating training slides. So slides that can be presented to employees prior to reentry, and then ensuring that with reentry that operations are sustained moving forward.
Yeah, I think that last point, Sam, is pretty critical. We talk about reentry and sustained operations. Why do we say sustained operations? Because whatever we put in place now, or whatever your workplace puts in place now, is something that obviously will be adapted, but we're going to have to live with until such time that we've essentially come to the tail end of this thing by vaccine or herd immunity. So this isn't a 2-week deal. This isn't a 2-month deal. This is potentially a 1 to 2 year deal. So thinking about that being said, it is worth the time to really evaluate this in a critical, methodical way. So we're going to show you some stuff that came out of our specific office, which, by the way, about 300 people in the Greenwood Village office of Merrick. That's the headquarters. So I'll start. I'm going to ask our much more intelligent epidemiologist to comment on this, but what we're looking at is the surrounding area in Denver, Colorado. And the Greenwood Village office is located in Arapahoe County, just southeast of Denver proper. And you can see that what we're looking at here is a 2-week cumulative incidence rate. And the darker orange, high incidence rate. The regular orange, if I can call it that, seems to be moderately high to moderate, all the way down to, in gray, pretty low incidence rate. And you can see Arapahoe County is sort of in that high zone. It's right around the Denver metro area. On the right, we're looking at a 3-day moving average of that, and you can sort of see that trend line over that. And what we have seen now in at least Arapahoe County is that we've got that decrease. Remember what I said earlier about the risk landscape depending on where you are on that side of the curve. This is a mini curve. We're looking at a curve in a single county, but those things might help inform where we are on the upswing in terms of incidence rates, and when it becomes more, I would say, less risky to go out and resume work. The other point that I would make is we're looking at Arapahoe County because that's where the office is located. That does not mean that that's where all the employees live, and we're going to go through that further. Sam, what did I miss on this?
Nothing, Ryan. I think, looking at data at sort of the county level, where an office a building is specifically located, I think that sort of highlights again the point that even though the state of Colorado or another state might start lifting some of those sort of those guidelines and start to begin to reopen, there's still these hotspots. I mean, I think the thing about COVID-19 is that there are still some areas that are experiencing an increase in the number of cases. And in this case, there has been a sustained decline in Arapahoe County. But I mean, I think, it's again, this phased approach, and really it's going to depend on that specific community and what the outbreak is looking like in that community.
Right, exactly. And then the other consideration, of course, Sam, and this is another thing, is that we know, I think that, scientifically, it's easy for us to say that as we start to loosen the reins a little bit, and that as people do start to come out of their homes, even in, a lesser capacity than they would have 6 months ago, we would also expect to see those, the incidence rate start to climb again. To what degree, to what magnitude has yet to be seen. But just because an area, county, city, et cetera, is in a sustained decline status now, doesn't mean that it'll be that way in 4 to 5 weeks. Let's move into a little deeper of our case study here. All right, so again, here we've got an office layout, pretty snazzy. We're doing some free advertising for Room Sketcher here. I really like their stuff. Let's talk about the environmental conditions. So this is actually the stuff that we have done and are doing for our Greenwood Village office. We're really thinking about the staff density. We're looking at employees that are close to high-risk persons. And you might think, well, is that a little bit invasive to ask your employees to divulge if their spouse is maybe an ICU nurse? Do they have proximity to that? I think, again, that's going to be weighed against your tolerance. And of course, probably some good heart-to-heart with your HR department. But we do need to think about, are there individuals that could present greater risk than others when we think about who do we let back in the building? What are the disinfection protocols? Do we treat visitors and contractors differently, than we do our employees coming and going? That's a tough one. I think, my perspective on that is that everybody, until we've got, 100% testing, wink, wink, everybody bears roughly the same risk. What about ventilation? We're starting to see some reports come out about the potential for the spread of coronavirus through ventilation systems. I think that's pretty marginal. We're certainly not, I think there's more data to be gathered there. I think that Sam and I both agree that in a broad spectrum of risk, that's a pretty low risk area. We're not advocating to our own company or other companies that now we're installing some crazy HEPA filtration system on commercial office buildings. That's just not a practical approach to this. As we'll continue to say, the primary risk comes from other people. Entry egress, we're looking for bottlenecks, elevators. We're looking at shared office space, areas of congregation like break rooms and conference rooms. Modes of employee transport. Why do we care how somebody gets to the office? Well, I certainly care, and we're going to talk about why. And of course, we've already mentioned, but where you are relative on that curve. So these are sort of the criteria that we've applied to our Greenwood Village office. Let's take a look at some of those exposure sources. Coffee maker, break room table, frequently used doors, congested areas, proximity to others. We really have to think about the layout. Of course, sneezing and coughing. I think those of us that have been in the infectious disease space for a while, we've always looked at, elevator buttons as just a disaster waiting to happen. I'm glad other people are now too. So we have to look at those exposure sources. So let's go through a couple of examples. I mentioned that modes of transportation to and from the office actually matter. So what if, this is hypothetical, but what if 25% of the employees are dependent on public transportation to get to work? So let me contrast Greenwood Village with another one of our offices, which is just outside of Washington, D.C. in Arlington, Virginia, Crystal City, right behind Ronald Reagan National Airport. Almost all of our employees are dependent on the DC metro system to go and come from work. And I can tell you that picture you're looking at wouldn't have been cringeworthy 6 months ago, and now you look at it and you start to cringe. That's a pretty normal day on the DC metro right there. So in other words, if somebody has a greater chance of being exposed because of the numbers of people that they come into contact with, do I need to think about that employee's ability to come into the office or not, compared to others? Greenwood Village, on the other hand, much more suburban area, south of Denver City, and most folks tend to drive independently, or perhaps they carpool if they are environmentally conscious. Either way, the way that people get to work actually matters. So what are some possible recommendations that may come from looking at this particular element of risk? Might be that employees that are dependent on public transportation, hey, we're going to open our doors in a limited way, but you guys that are taking the metro or the subway, you guys keep teleworking. Maybe now, and maybe this may not be specific to those that come through mass transport, wash your hands as soon as you walk into the workplace. That's got to be mandated. Or maybe there's a shift schedule approach where people who use mass transit are not necessarily in the office at the same time as people who do not. How about the office? I love this one. Think about your call centers. Office cubicles are 2x4 with 24-inch dividers. You're going to spend 8+ hours a day crammed in there, and you don't know if your neighbor has something or not. I'm not trying to be fear-mongering whatsoever, but we have to deal with the potential risks that are coming from this. So the potential elements of risk in this scenario, obviously the personnel are going to be too close together. We cannot have these workstations completely filled and maintain a safe physical distance. So what are some possible recommendations that come out of this? Again, this is based on the institutional risk tolerance, what you're willing to accept as risk and what your employees are willing to accept as risk. Maybe you got to reduce the workspace to 50% capacity, so every other person. Maybe in addition, or you're looking at increased surface disinfection practices. Additional higher dividers, right? Increase that barrier between people. And again, shift schedules. This could be either or. So we've taken you through a few examples. I hope we've explained, we're not done yet, but I hope we've explained what, how we've been able to take certain elements of a PHRA, apply that to an analysis. So what is the value of doing this as opposed to, just sort of gut feel, or, you know what, we're going to do broad stroke and we're going to say, we're going to allow 25% of our workforce back now, and we're going to wait a month, and then we're going to allow it to go up to 50%. What are those numbers based on? We have to think about what those numbers are based on. So taking a risk-based approach, which is what we're describing here, does a couple of things. It really provides for site-specific considerations. We want people to think critically about how their work environment operates. That means the areas of congregation, bottlenecks, disinfection practices, how many people are there and when. Going through this process might start to reveal some not so obvious risks. We really want people to play the tape forward. And why do I say that? We say that because this is not a situation we're going to live with for another couple of weeks or another couple of months. This is a situation we are likely going to be living with for 1 to 2 years. This is also going to force institutions to really think about what is their tolerance for risk, what are they willing to accept, and what are the potential consequences of that. We're not even going to get into the legal issues. I think that is a completely new game, and I have no idea what that looks like, and I'm not a lawyer. But it is important for entities to think about what is their tolerance for risk. We also want confidence to be built in the leadership and the employees. We want, particularly for our own employees and our own company, we want our folks to know that our return to work approach is not just based on pulling numbers out of the air, percentages of employees going back. It's actually based because we've analyzed the risks in a methodical way, and we've made those determinations. We also want the employees that come back, we want them to have confidence in their own behaviors as they navigate the new world. And of course, this really builds awareness of risk management. So agree or disagree on the PHRA analogy, but I hope that all of us can agree that taking a risk management approach to inform how we decide to go back into the workplace is a prudent practice, and it's something that will be backed up by an actual process. Sam, I'm going to hand it back over to you for the remainder of the session.
Thanks, Ryan, appreciate it. So just in terms of where to get reliable information, I think, as part of COVID-19, there's been a lot of information that is either portrayed or conveyed in social media and news, online, and it's hard sometimes to know what information is trustworthy, is accurate, and is reliable. So we wanted to take a couple slides to specifically show where you can get reliable information. So in terms of general information about COVID-19, and because information is constantly changing with this pandemic, I think some good resources for just general information, whether it's the changes in signs and symptoms, whether it's how the disease spreads, whatever it might be, the best place is CDC, Centers for Disease Control and Prevention. Another good website would be WHO. Both CDC and WHO are incredibly reputable in terms of their guidelines that they issue and in terms of the information that they provide. As I mentioned, there's been a lot of myths in terms of COVID-19, what coronavirus is, what it isn't, what's effective in preventing or treating COVID-19. So FEMA has actually has a site dedicated to displaying any rumors. So highly recommend that site. Also, given that every state and even locality is a little bit different in terms where they are with the number of cases and whether cases are declining or continuing to rise, I encourage anyone to actually visit their state health department website for further guidance and information. In terms of disinfectants, so I know that there's been a lot of questions out there, and the primary way that COVID-19 is transmitted is through droplet transmission. But in terms of looking at and thinking about fomites and the fact that the virus can linger on surfaces for periods of time, and that the amount of time that the virus lingers on surfaces depends on the surface. So disinfecting, cleaning. There's been a lot of information out there in terms of what are the best disinfectants, and the EPA has a great list of those disinfectants that are most effective against the virus. Another good resource, the CDC, has some interim recommendations for U.S. households with suspected or confirmed coronavirus cases. So If you have someone in your family that is sick, or you are already caring for someone someone with COVID-19 who's sick, these guidelines really help to explain what it is that you can do, some measures that you can take to ensure that your household is safe and that you can protect yourself while caring for a loved one. For those that are curious about the number of cases, and given the fact that the total confirmed cases worldwide, but also cases in your particular state or city are constantly changing, highly recommended COVID-19 dashboard, which is put on by Johns Hopkins University. Johns Hopkins also has great information for various situation reports or journal articles that are objective, and those can be found on the Johns Hopkins Center for Security Policy website. For reentry guidelines, COVID-19 technical guidance for schools, workplaces, and institutions, the World Health Organization, WHO, has some good information on how to think about reentry, whether it's in the school, workplace, or institution, and some of the things to think about from a business and institution perspective. Another good site, again, CDC, has some information about implementing safety practices for critical infrastructure workers who may have had exposure. So this is looking at, entities that someone where there might have been a small case, a small cluster of cases rather, at a particular entity, a business, and how that employer should handle things, whether someone has been exposed at their particular site or if there is suspicion that someone has been exposed. The final portion of our presentation is really going to look at the importance of personal accountability. Ryan talked about how entities can mitigate some of the environmental conditions and exposure pathways by specifically looking at what they are at a particular site. But ultimately, we want to think about what employees can do as they start to re-enter into the workforce. So contributing to personal and peer health. As we think again about returning to the workplace, most of the risks to employees are the employees and how they behave. Everyone needs to be mindful of their personal and peer health. This really includes limiting contact with others. Obviously, depending on the layout of an office or workplace situation, it may be hard to distance yourself from your peers, but it's incredibly important to still try to limit the contact with others. Remember, the new normal is not the old normal. So companies may decide to reopen in a phased approach, and employees may rotate when and how often they get in the office, whereas others are still going to telework. So it may not be 100% of employees returning to the office. It still might be 25%, but it's important to continue to maintain limited contact as best as possible. Washing your hands. I know this has been said and really needs to continue to be said, but the single most important thing that anyone can do is to wash their hands frequently for at least 20 seconds each time. Washing them regularly when you're at the office, when you come home, before you eat, and other times that you are touching surfaces. This is especially important for very communal surfaces, whether it's a copy machine or the coffee maker in a break room. If you don't have access to soap and water and being able to wash your hands right away, you can use a hand sanitizer that contains at least 60% of alcohol. And certainly people need to be mindful of touching their eyes, touching their noses or mouth, since the virus can enter the body that way. It's important to wipe down objects and surfaces frequently with household cleaner, which kills the virus. We talked about maintaining social distance, and I think entities really need to think about how best to do this in their office, and whether it's sort of rearranging furniture or putting in shields to separate cubicles. But the idea is to maintain a distance from people, and this is especially important if someone might be sick. Wearing cloth face masks. We'll talk a little bit more about this in just a second, but the importance being that people should be wearing face mask, even in the workplace. And talked about social distancing. And, I think the big thing is limiting in-person meetings and conference room gatherings. So as part of limiting contact with others, maybe even though people are returning back to the office, it's still important and worthwhile to maintain teleworking and also maintain teleconferences and continue out those Zoom meetings. I definitely recommend doing that as well. Now we're going to look at the do's and don'ts of face covers. So in light of new data about how the virus spreads, along with evidence of widespread COVID-19 illness in communities across the country, CDC's recommended that people wear a cloth face covering to protect their nose and mouth in the community setting. Face coverings are not a substitute for social distancing, but a cotton mask can dramatically reduce the number of virus particles emitted from our mouths by as much as 99%. So fewer virus particles means that other people have a better chance of avoiding infection, and if they're infected, the low viral exposure load may give them a better chance of contracting only a mild illness. That's why it's important to wear cloth face coverings, and I think is important to continue to wear them in areas of widespread COVID-19 illness, particularly in the workplace as well, just because the virus is, you might not feel ill and you might be sick and you might be at work, and therefore you're potentially exposing some of your peers. I think some do's and don'ts. The masks are meant to be washed regularly. Want to make sure that they are dry. You want to make sure that they actually cover your face, so cover your mouth and your nose, and that they are tight around your face. This is not a substitute for surgical masks or N95 respirators. These are still in short supply and should be reserved for healthcare workers. And if you touch the front of your mask, then you want to wash your hands right away or as soon as you can. So why is it important, why is it so critical folks take personal responsibilities? As cliche as it sounds, we've heard this before, but we really are in this together. And ordinary people can have an impact. I think that's one thing a lot of people don't quite realize in this pandemic. I mean, I think governments could and should do much, make tests widely available, fund research, and ensure that medical workers have everything they need. But ordinary people like us, as we return to the workplace, can have an impact and maybe even have more power than we realize. We can protect ourselves and we can protect others, along with keeping our distance wherever possible and maintaining good hygiene. All of us wearing cloth masks could help stop this pandemic in its tracks. On that note, we'll end on some do's and don'ts as we think about re-entering into the workplace. So just to reiterate some do's, washing your hands often, cannot emphasize that enough. Follow the policies and procedures of your employer related to illness, work meetings, and travel. Just because you are returning back to your office doesn't mean that there might be different protocols and policies in place deemed by leadership. Making sure that you're cleaning and disinfecting anything that you touch in the offices, and that surfaces are regularly disinfected, and maintaining that social distance. In terms of don'ts, don't go to work if you're not feeling well, or even if you have a family member who's not feeling well. Refrain from touching your eyes, nose, and mouth with hands that might not be washed. And when you get back to the office, do not use other employees' phones, desks, office. Try to keep your hands on things that are yours to help mitigate the spread of disease. And I believe that concludes our presentation. Ryan, any final thoughts, comments?
Yeah, I certainly want to thank folks for signing in today. We are just at the 1 hour mark. We do have a few questions, Sam. One of the most popular questions that has come in is, will we be providing a copy of the slides? What we will do is we will be posting a recording of this webinar that you can access on demand. Sam, we've got a true question here for a good epidemiologist, and that is, what percentage of the population, effectively has to become infected / recovered to reach what we might define as herd immunity?
Yeah, that's a great question. I think one thing that is still not necessarily known about COVID-19 is that if you have it, that you are going to be immune to it. So when we think of herd immunity, we don't know for sure. So that's one thing. I think the benefit of something like serology testing, where we're starting to test people's blood and look to see if they have developed an antibody to the virus. I think that's going to be critical to better understanding whether or not, what percentage of the population needs to get sick before we can prevent other people from getting sick. So I think that typically we would want to see greater than 50%, but given how unique COVID-19 is, I think we really need to do, again, more serology testing to better understand if people do actually develop antibodies. And if they, just because they have it, doesn't mean that they might, not be at risk for catching it again.
So that's sort of related to the second question, which is really about, is there really a benefit to the individual and therefore society by rolling out antibody testing?
I think so.
Yeah.
Yeah, I definitely think so. I mean, I think, for the reason that I just said, we don't know if people are going to develop an antibody. We're also not sure, similar to seasonal influenza. So seasonal influenza, the virus tends to change and mutate. And we have seen some slight changes and mutations in COVID-19. I think it's been a little bit infrequent, but who's to say that, in a couple months from now, people who may have built immunity to COVID may no longer be immune if the virus continues to mutate. So we might see COVID-19 become very similar to influenza, where it's going to change. It's going to change over time.
Right. So we have a question that's about, what are the expectations of the employer in terms of providing masks and things like that? And I would say that that's an institutional decision. I can tell you that Merrick has made the decision to provide cloth masks, reusable cloth masks to all employees at office locations. That's a choice that Merrick made. We realized that there are a lot of resources where folks can learn to make their own cloth masks, or they could obtain them through other means. And it's up to the company to make that decision. Another one that we've asked a lot, and I say that would apply with not just the face masks, but hand sanitizer, anything that individuals may need to keep their hands in their space clean. One question that we've been asked a lot is about the use of thermometers. Is it proper, if you will, for an employer to require temperature testing before you walk in the door? Again, that's an institutional decision. We don't have a strong answer for that. I can tell you in Merrick's case and what we have recommended is that, again, to Sam's point about taking personal accountability, we will expect our employees to monitor their own health and to be honest and transparent about it. And that means that maybe their daily routine now is you get up, you shower, you brush your teeth, and you take your temperature. Maybe there's a new getting ready for the day kind of model. Those are institutional decisions, and what I would suggest you do is you go back to that risk assessment and ask yourself the question, if we don't do this, if we don't do X, what are the potential consequences? And then say, how does that align with our risk tolerance for what we're willing to accept? Those are the decisions that really have to be made at an institutional level. So let's see, I'm just scrolling, Sam, to see if we have any others. We've got a couple here. I think we've addressed most of them. Okay, great. Now, for those of you that are still on the line, we do have a couple of poll questions. And we're going to launch those. Please feel free to participate or not participate. If you want to stick around, we've got 5 very short polls. Poll questions, yes, no questions. Just curious about our own audience here today and what your all's perspectives are. So I'm going to launch that first poll question, and hopefully that will be open and you will see some controls to actually vote. So the first question being, was this webinar helpful for you and your institution? We'll give it a few more seconds to vote. We certainly hope it was. We tried to keep this somewhat high level. One thing that we want folks to be aware of is that we feel strongly that there is a benefit in taking a risk-based approach to inform your strategies. We certainly want others to sort of ascribe to that belief as well and use that. We think that there's real value there. And that means, and again, you don't have to be a risk professional. Obviously, there are consulting firms like us. We do this for a living. We're happy to help institutions perform risk assessments based on their site-specific considerations. If that is of interest, please call us. If not, we hope this was helpful. We want this to be a good resource. All right, we've got about 70% voted, and the answer was 100% there. Fantastic. Let's go to our next question. Has your company drafted a return to work communication piece? We'll leave that open for a little bit. That's my dog barking in the background. Can't believe we made it this far without that. All right, a few more seconds on this question to vote. All right, I'm going to share the results. 73% are in progress, 14% say no, they have not started, and 14% say, yeah, we did it. Great. Most people are in progress, totally get it. For those of you that haven't, we hope this was useful. For those of you that have, maybe this will, address some other points. Let's go to question number 3. This is your company or institution only considering federal, state, or local guidance with respect to your return to work? Or are you taking a site-specific approach? All right, we'll leave this one open for a few more seconds. All right, gonna close the poll and share the results. Interesting, 25% don't know what our company or institution is doing. My recommendation, ask. 69% said no, as in no, we're not just listening to perhaps the politicians, not to generalize, but we're looking at things at an institutional specific perspective. And 6%, the minority view, said, yeah, we're going to open our doors or think about opening our doors based on the guidance that we've received from that. I would say question that. Look at that risk-based approach. This isn't a one-size-fits-all situation. Let's go to question number 4. Now that we've done this, we want to know, you've seen sort of a science and a risk-based approach. Is your company interested in having that type of approach? For those of you that haven't, or you're in the middle of your process, we wonder if this was like on par, if this was like, I don't know, no, we're good with our federal guidance, or you know what, we got all the brain power we need, or is it, no, we see value in using science and risk-based approaches. So we'll leave this one open for a few seconds. I appreciate you guys hanging on to do this, because these are very, this is educational for us as well. We also realize that various institutions and workplaces different. Not everybody is an office, right? Not everybody's a call center. There are a lot of different types of workplaces out there where, you know, various approaches might be better served. Leave this one open a few more seconds. All right, let's share the results. About 68% of you said, yeah, we would be interested in using a science and risk-based approach. About a third of folks said not sure, and 4% said no. All right, final question. This is an important one. Is your company prepared to leave the guidance you develop in place for a sustained period of time, knowing that it's going to be a while before there's a vaccine? In other words, what Sam and I refer to as the new normal, we don't even know what that is yet. That's a ways out. So whatever decisions we make now, whatever workplace we create now, is something we're going to have to be able to live with for quite a while. Leave that open for a few seconds. All right, gonna close it and see where we got. All right, 52% of respondents said, yep, we're prepared to leave these in place. 41% said, you don't know. I think that's a good, honest answer. Who knows, right? I think there are gonna be changes to it. 7% said probably not. So really interesting. Appreciate you guys answering those poll questions. That's educational for us. We really hope you found this useful. I want to thank Kelsey, Judd for hosting our webinar today. I want to thank the lovely and talented Samantha Dietrich for her contributions, and thank you all for attending. This will be recorded. And we will send out a link as to where that will live. In the meantime, please reach out if there is something we can do to support safe and confident reentry back into a very uncertain environment. Thanks, everybody. Have a wonderful day.